Hi, I'm Beth Van Opstel. I'm the Pediatric Clerkship Director here at Rush, and this is a lecture about fluid and electrolytes for peds. I will totally be honest and say that fluid and electrolytes, at least when I first started giving this lecture, was not the most interesting topic to me. But I have come to grow and love this topic, and I hope that you guys will come to appreciate it, at least, even if you don't enjoy it, but hopefully you'll enjoy it, that it's really important in pediatrics. So here are learning objectives. We're going to identify the three main components of fluids. We're going to talk about maintenance fluids with the Holiday Seeker method as the most common way to calculate maintenance. We're going to talk about both oral and IV fluids for hospitalized children or children who are dehydrated and how to calculate how to make up for that. And there will be many pictures of my kids because it's fun to make fun of them and have fun with them. And I can't get in trouble for stealing other images off of Google. So below you'll see when my daughter was trying to shoot water guns at my son, who was not so happy about it. And all the themes revolve around fluids. Okay, so in normal healthy people, how do we lose water and solutes? Okay, so in kids and in adults, there's different ways that you lose water. One is from insensible losses. So this might be things like your skin or in your lungs. And then you combine this with sweat, and this makes up about 35% of our water loss in a day. Then we got stool, one of the least fun things about peds, or adults for that matter when you're a doctor. And that makes up, in a healthy person, about 5%. And then you have renal loss, which is usually pee. And that makes up about 65%. But then you got to think about, in any kid who's sick, how these percentages might change. So if you have a baby who has, for example, bronchiolitis and who's really tachypnic, this insensible loss of 35% is going to go way up. And it'll be really hard to calculate how much that is. Or similarly, if you have a child who has asthma and is wheezing, I like to make breath sounds in peds, even though they really don't sound like the real thing, but they're wheezing and they're really tachypnic, then that insensible loss is going to go up again. Or, by comparison, if you have diarrhea, then your stool could go way up. Or if you have a problem with your kidneys, it could either go way up or way down. And so you always have to think about these shifts in body, in fluid loss and in water loss. So what makes kids different? Here's my littlest of babies. So babies are chubby, they have all these skin folds, you can see all these cute little folds, they have folds in their arms, they have folds in their legs, their thighs, their belly, and it's really cute until you get older. And so it makes them have a higher body surface area, and so then they have higher evaporative losses. They also have higher metabolic rates, higher rates of ketosis. And even if you don't know a lot about babies, you know that they need to eat more often. I remember one of the things most intimidating to me about peds was trying to figure out what's normal eating schedule for a baby. So for example, I'd be in the ER and the mom would say, well, the baby's not having as many wet diapers and they're not eating as much. And, I'd kind of nod my head like I knew, and they would say, well, they're only eating, 2 ounces. And I would have no idea if 2 ounces was normal. So it's good just to ask parents how much they eat. And then there are ways that you can actually figure out how much they should be eating for their age. But in general, just know that an infant, for example, in the first couple weeks and especially and even months of life is probably going to eat every 2 hours, every 3 hours. And they can't go very much longer without eating. And then they have a different body composition of water. And this kind of goes back to the cute chubby baby if you think about it. But they have a higher percent of their body weight that's water. So in a baby, it's about 80%, which is different than what you've learned about in the older adult, which is 60%. I don't know how this really looks like an adult, but it's different. And so as you gradually transition from that infancy all the way up, here, let's make a little kid so then you can tell, up to the adult, it's somewhere in between. So a school-age child, you might be getting closer to the 70-ish percent. And you have to think about that when then a kid comes in who's, for example, dehydrated, and take that into account when you calculate your fluids. Okay, so for every normal healthy child, and for adult for that matter, there's a certain amount of sodium and potassium that you have to take every day. Most of us as Americans get way too much of the sodium, but it's about 2 to 3 milliequivalents per kilo per day, and potassium is about 1 to 2, and usually we get our chloride just by meeting our other requirements for our sodium and for our potassium. Okay, that being said, then you have to think about when you're giving somebody fluids, what's actually in the fluids that you're going to give them. So, in pediatrics and in internal medicine, you'll see a lot of 0.9 normal saline used the most, versus some of your surgical floors, maybe you'll see a lot more lactated ringers. It doesn't have to be that way. There are lots of studies that in most settings they're probably pretty equivocal, but it's good to know what's actually in them. So as far as what's actually in lactated ringers, the sodium concentration is about 130, and the chloride concentration is about 110. In normal saline, it's 154 of each. Oops, 154. So it's equal. NaCl, so it's equivalent of each. And then 0.45, which you'll hear people call half normal saline, is just half of 154. So that's 77 and 77. And then 0.2 normal saline, which you won't see used many places, but maybe you'll see it, for example, in the NICU, or very, very occasionally you'll see it used in the Gen Peds floor, is 34 and 34. But there might be special cases where you might want to pick depending on the electrolytes of a patient. So, for example, if you had a hypernatremic patient, then you might think of using some of these other formulas. One difference about lactated ringer is that they also have some other things in there too. So they have 4 of potassium. So you'll hear that there's a little bit of potassium. It's not actually that much. And 24 of bicarb. So that's nice to remember when you're thinking about solutions to pick, because maybe, for example, if you're thinking about a patient that has diarrhea versus vomiting, it might influence knowing that there's bicarb in there. So the way I try to remember it is if you have a patient who is having lots and lots of vomiting, then they're essentially, and this is basic, but you're throwing up, you're vomiting HCl, so you're losing lots of acid. So you wouldn't want to give them something back that has lots of bicarb in it. But conversely, if you have a patient with diarrhea, and with that diarrhea they're losing alkalotic fluid, maybe you might think about using lactated ringer in that patient instead of normal saline, which doesn't have any bicarb in it. So just something to keep in mind. Now remember, isotonic to the body is 140 milliequivalents per liter. Plus, on top of that, usually for all your maintenance fluids, you do want to add some potassium because it's one of the necessary electrolytes for your body. Now, usually this just comes in bags, or it's easiest to make when you order it in 20 milliequivalents. You can order it in 10, or you can even, if you really had to, if you're making your own bag of solution, you can do it in smaller increments. But the pharmacist will think you're a little crazy if you try and add potassium in 17 milliequivalents to the bag, unless there's a very, very specific reason, or again, the NICU is kind of its own world, so the NICU it might be different. But in general, we'll add a little bit of potassium, assuming they have no kidney problems and no electrolyte problems with the potassium itself. Usually in kids, we also add dextrose. Why? Because, as I told you, kids are at higher rate of ketosis than adults, and they need dextrose. There's actually some new adult literature, too, suggesting that perhaps we should be using dextrose more in our adults. Often you'll see the culture of medicine is that you put people on 0.9 normal saline as their maintenance, and even if they're NPO forever, it takes us a long time to add dextrose. So think about adding dextrose. But 5% dextrose, which is standard to be added to a bag, is only enough calories to prevent ketosis. You will lose weight if all you're on is a little bit of is 5% of dextrose. And this is my crazy son, who is obsessed with his little brother and loves touching his head and is helping me feed him, but is so obsessed with his brother that he even wanted to rub his belly along his soft head. He loves his soft head. So cute. But the point to remember is that babies can't go very long without eating, and maybe this crazy picture will help you remember that. So add dextrose. Add your dextrose to your solutions. Okay, there's 3 components of fluid therapy, which we're going to go over in separate videos, but there's maintenance fluid, deficit, and replacement. So maintenance, what you need, is what you need for just normal daily losses. Your deficit is what you make up for what's already been lost prior to being seen. So for example, a kid with vomiting and dehydration, you got to make up for that fluid that they've already lost when they present to your clinic or to your ER. And then there's replacement for what your ongoing losses is. Okay. Another point